recorded. So welcome to the Direct Care Resilience series. This project purpose is to expand agencies' leadership's capacity to support employee mental health. We also aim to build direct care professionals' resilience skills by increasing awareness of mental health self-care and provide some resources to help sustain and strengthen the current workforce to limit staff turnover. The series has 3 focus areas with sessions tailored towards creating organizational cultures that support mental health. We have supervisor strategies to mitigate and prevent employee burnout, and evidence-based coping strategies for stress management and building personal resilience. Today's session is trauma-related or trauma-informed practices, so it kind of falls under those evidence-based coping strategies, and it's also just a really great introduction to the impacts of trauma. So your participation is the key to our ECHO sessions. We really want to create an interactive community where our presenters, stakeholders, and members all communicate and support each other during a session. So we encourage you to turn on your camera as long as you're comfortable doing so. And we appreciate when participants are engaged in asking questions after the didactic and provide feedback for the case presentation. These case narratives are the best way to solidify the skills learned in the didactics and receive direct advice. So please feel free to upload your questions into the Zoom chat, and we'll address them throughout the presentation if you have questions during the presentation. You can earn professional development, social work, or nursing credits. We also provide certificates of completion for your participation in this series. So to receive credit, we just ask that you fill out the evaluation that we'll send out after this session. So we'll go ahead and get started with some introductions. I'm Krista Opstedal. I'm the Project ECHO Director here at the North Dakota Center for Persons with Disabilities at NDCP or at MSU. Jody, do you want to go ahead?
Hi, I'm Jody Patchen, and I am the Project Administrative Assistant. Kyle?
I'm Kyle Erickson. I am the project evaluator for ECHO, and I'll also be your case presenter today. So we'll talk to you all in a bit.
I'm Jessica Reiswig. I'm one of the project coordinators on Project ECHO at MSU.
Thank you, everyone. And we'll go ahead and pass it over to Dr. Kayla Bethley. So thank you so much for being here, Dr. Bethley.
Thanks for having me. So I'm Dr. Bethley. I teach at the University of Mary, focusing primarily on the general psychology classes, child and adolescent psychology, and then a variety of classes that I teach online. Looking a little bit at my employment history, I actually worked at Pride Inc. here in Bismarck for 5 to 7 years. I worked as a youth mentor, so working with children that had some type of disability or diagnosis. And then I also worked at what we called YRS, so Youth Residential Services. So I worked with teens that had drug and alcohol addictions. And in addition to that, we also had a safe bed unit. So children that needed to be removed from the home, either for their safety, for their parents' safety, or that just needed a little time apart. So I have worked in many of the same positions as some of you have. And then I was also a school counselor for 10 years before coming out to the University of Mary. So first off, thank you in advance for allowing me to present on this very important topic of trauma. Gaining knowledge on this topic is very valuable for the fact that many of the people that you serve can be vulnerable at any point in the life cycle of traumatic events. Because your consumers, your tenants, the individuals you work with may have a limited knowledge base, may struggle with social skills, verbal skills, they are more vulnerable and actually at a higher risk of being exposed to some type of traumatic event. So looking at what our schedule looks like today, first of all, we'll be going over ACEs. So ACEs are...
Dr. Bethley, I don't think we can see your slides.
Oh, no. Okay, let me end the slideshow and share. Can you see it now?
We can see your desktop screen.
Okay, perfect. Let me.
Perfect, there it is.
Okay, I wonder where it disappeared to. Okay. So looking at the content for today, first of all, we'll be going over what are ACEs. Those are going to be adverse childhood experiences. We'll be talking about the response and symptoms of trauma. So what is this going to look like in your clients? And then how can we help our clients that have experienced trauma? Then when we work with individuals that have experienced trauma, that can lead to us ourselves having what we call compassion fatigue, or sometimes having that secondary trauma, vicarious trauma. So how can we help ourselves when we are experiencing those types of things? And last but not least, what does a trauma-informed framework look like? What does it look like when the entire organization is participating in trauma-informed practices? So first off, what is trauma? So the definition of trauma is when we experience very stressful, frightening, or distressing events that are difficult to cope with or are out of our control. It's important to note that when we are talking about trauma, it could be a one-time incident, or it could be incidences that are happening over that longer period of time, a repeated type of incident. I am going to start with about a 5-minute video that discusses.
What does your parents' divorce have to do with your risk for heart disease? If your mother had a drinking problem when you were growing up, are you more likely to suffer from depression as an adult? Here's what you should know about ACEs. ACEs stand for Adverse Childhood Experiences, extremely stressful events that can happen to a child growing up. Some experiences are so stressful that they can alter brain development, as well as the immune system, increasing the risk of lifelong health and social problems in adulthood. The term comes from the Adverse Childhood Experiences Study, landmark research that shed new light on the root cause of everything from stroke and liver disease to substance abuse and mental illness. In the late 1990s, an epidemiologist from the Centers for Disease Control and a preventive medicine doctor at Kaiser Permanente set out to understand the association between childhood experience and lifelong health. They asked over 17,000 people in the Kaiser Health Plan in San Diego about their health history, as well as difficult questions about their experiences growing up. Anda and Felitti tallied up 10 different kinds of adversity in this largely middle-class and college-educated population. They were stunned to see how common ACEs were. 21% of all respondents were sexually abused as children. 19% grew up with someone who suffered mental illness. 28% had been physically abused. And 2 out of 3 respondents had experienced at least one ACE. The researchers next looked at how someone's ACE score, or the number of adversities they experienced, related to a wide array of serious health and social problems. They saw that the more ACEs someone had, the greater their risk for poor outcomes compared with someone with no ACEs. Someone with an ACE score of 4 had twice the risk of heart disease and cancer. Someone with an ACE score of 5 had an 8 times greater chance of being an alcoholic. And those with an ACE score of 6 or more, on average, died 20 years earlier. With every major problem they looked at in the ACE study, the risk went up for each additional adverse experience in childhood. As Dr. Robert Anda says, what's predictable is preventable. It's important to remember that ACEs are not destiny. ACEs are a tool for understanding the health of a population as a whole. For individuals, an ACE score can be a tool for understanding their own risk for health and social problems and empower them to make changes for themselves and their children. ACEs tend to get passed down from generation to generation and are common across all income levels, races, and cultures. But increasingly, people of all different professions and backgrounds are coming together to discuss how ACEs affect their communities. They're finding new ways to treat and prevent ACEs. Many doctors are starting to screen their patients for ACEs as part of their medical history. More schools are becoming trauma-informed, considering the source of problem behavior when disciplining their students, instead of immediately suspending or expelling them. To learn more about interrupting the cycle of adversity and improving health and well-being for the next generation, please visit kpjrfilms.co.
So that was a nice overview of what we'll be talking about here on the next couple of slides. So they talked about the fact that they looked at 10 different areas when we are discussing ACEs, or those adverse childhood experiences. So first of all, it's going to focus on that area of abuse. Has that person experienced physical abuse, emotional abuse, sexual abuse? Next, we're going to look at neglect. Has that person ever experienced physical neglect? What about emotional neglect? And then last but not least, they're also going to look at household dysfunction. And I think this is a really important area to look at, especially when we know that about 64% of US adults have experienced at least one ACE. 23% have experienced 2 or 3 ACEs. And about 17% of individuals have experienced 4 or more ACEs. That is quite a few ACEs. But when we sit and actually look at household dysfunction, studies are showing about 1 in 2 Americans will receive some type of psychological diagnosis in their lifetime. So that's 50% of Americans. So right here, it talks about the fact that household dysfunction, having somebody that has mental illness, having somebody that has experienced depression, that is all going to fall under that category. Next, we can look at incarcerated relative. So do you have a close family member or a family member that lived in the home that is in jail? Mother treated violently. And here they're talking specifically about physical type violence, but I would also argue if there is a lot of conflict and severe significant arguments in the home, I would think that could also qualify under an ACE qualifier as well. Substance abuse, so this can be drugs, alcohol, it can be prescription medications. That will all fall under substance abuse, and then divorce. Studies are showing that divorce rates are about 45% of married couples. So think about how many people you know whose parents were separated, were divorced. That is going to be an ACE if that occurred for that individual. So it is very easy to see how so many Americans have at least one ACE, if not 2 or more. So why is this so important? When we're talking about the 90s, early 2000s, things that happened in childhood, we should be able to move past that. As adults, we should be able to move past that trauma that occurred. But we are seeing that's not necessarily the case. The trauma we experience as a child has long-term effects. Toxic stress from ACEs can change how our brain develops and affects how our body is going to respond to stress. It's going to put our brain into that lower mode, kind of that mode where it's going to be in that fight or freeze response, instead of going into that learning mode where we feel safe and can take in new information. ACEs are linked to chronic health problems. We can look at obesity, diabetes, depression, stroke, cancer, COPD, and even broken bones. So we do know that what is occurring to somebody as a childhood does have long-term implications. It has those biological implications, psychological, and we can also see how it impacts individuals socially as well. There is a link here. I can share it with you if you want to find out your own ACE score, or if you were just to type in ACE studies, you'd be able to see a score that way as well. So we see a lot of people that have trauma, but it's also important to remember this too. ACE scores don't tally the positive experiences in early life that can help build resilience and protect a child from the effects of trauma. Having a grandparent who loves you, having a teacher who understands and believes in you, or having a trusted friend you can confide in can all help to mitigate those long-term effects that we see from early trauma. So ACEs are only going to look at those negative things. It is not going to look at those positive qualities somebody may experience as well. So when we're looking at the ACE study, really we're looking at those 3 areas of abuse: emotional abuse, physical abuse, sexual abuse, and things that are going on in that household. It doesn't take into account those things such as natural disasters, accidents, or invasive medical procedures. Think about getting into a major car accident. That is going to leave some long-term trauma. It's going to have some significant psychological effects. What about losing your home in a hurricane or tornado? Those are going to have long-term implications as well. So yes, the ACEs is very important. It's important to keep that in mind when working with individuals, but also know that trauma can extend past those qualifiers that are discussed in the ACEs study. So our human body cannot function optimally if our basic needs are not met. And this kind of leads us to Maslow's hierarchy of needs. Really, at those base needs, we need food, water, warmth, rest. I often think about the students that come into my office as a school counselor. Maybe their parents got into a big fight last night. Maybe they had to stay up all night watching their little sibling because mom or dad had to work and nobody else could watch them. Do you think they're going to come to school ready to learn? If they didn't have food the night before, do you think they're going to be able to be ready to learn if they're hungry? Absolutely not. So when we're working with individuals, we need to make sure that those physiological needs are met first, because if those are not met, it's going to be hard to meet any other needs that they have. Next are going to be those safety needs. People want to experience order, predictability, and have some control in their lives. Once that need is met, we can then look at love and belongingness. This need is especially strong in childhood. We can look at attachment issues that can develop if a child does not feel love, if they do not feel belongingness. So one thing to remember, especially when we're talking about children, is that need for love and belongingness can override that need for safety. So think about that child who clings to an abusive parent, or even into adulthood. Think about maybe a female that stays in an abusive relationship. They may have that need for that love and belongingness, which is overtaking that need for safety. And that can be something that is learned or that develops through that experience of trauma. So what are some of the trauma symptoms that we can see long-term? Well, first off, sleep disturbances. Maybe that individual is not sleeping enough, having nightmares, sleeping too much, an exaggerated startle response, numbing, emotional constriction, that shattered self-identity. And trauma responses often represent a significant change from a person's normal level of functioning. But if they experience trauma as a child, you may not know what that individual's normal level of functioning is. Many trauma-related symptoms can mirror behavior of somebody that has a developmental disorder. For example, we can look at self-injury. We can also look at the fact of what came first, the chicken or the egg type of questions. Were traumatic events at least the partial cause of a developmental delay or disability? Or did that traumatic event occur with a client who already had a developmental disability, making that disability more profound and problematic? Some good news is that research on neurobiology looking at that brain of trauma has really shown that the brain has more capacity to heal, to change than we originally thought. It can regenerate, it can create new neural connections for healthy adaptation when that individual is in a healthy environment. So if we take a person out of a negative environment where there may be a lot of trauma, we can work with them, we can engage in different techniques to help regenerate or create new neural connections. So trauma information. It is important that normal trauma responses not be attributed to the person's developmental disability or pre-existing mental illness. People with developmental disabilities generally have the same types of symptoms following trauma that anyone else would. So somebody that has a developmental disability or delay is going to have the same type of symptoms of somebody that does not, that does have that average cognitive functioning. We already went over some of those symptoms there. And then when we're talking about that normal level of functioning, sometimes we might need to do some investigation, especially if you've just started working with the client. Or like I said, maybe that trauma occurred earlier in life. Maybe we need to talk to a parent, a previous caregiver, and find out, is this normal behavior for an individual, or is this something that has come on suddenly and is a change from that normal level of functioning? So how can you help your clients? Well, first of all, follow routines. As we said before, that safety, belongingness, knowing a routine, knowing what's going to happen next is important. So maintain routines. Give the individual choices. Often when we're talking about traumatic events, it involves that loss of control or that person experiences chaos. So especially when we're talking about children, giving them choices is going to be really important. It helps give back that control. It can be as simple as, would you like to do the dishes first, or would you like to do your laundry first? Really simple, give them two choices. Give them the option. They feel like they have more control over that situation. Obviously, it's going to be increase that support and encouragement. Maybe designate a staff member or another adult who can provide that additional support, because I know how it is to have a high caseload, to be working with multiple individuals. Sometimes we cannot always offer all that extra time to give the support they needed. But is there somebody in that person's environment that can be that support person for them? Another one that's really important is set clear, firm limits. Set firm limits in terms of what is inappropriate behavior. And when that behavior is inappropriate, develop logical rather than punitive consequences. So I have had multiple incidences where maybe a parent is unhappy with a child's grade, or the parent was unhappy with the teacher their child was assigned. They'll call me, yell at me, and sometimes it's just okay to put boundaries down, put limits down and say, I understand your frustration, but it sounds like we're pretty intense right now. Maybe it would be better if we talk again in 10 minutes, or maybe it would be better if I could call you back in an hour when you're not yelling at me. It's okay to put those boundaries in. Or if you're in the home setting, if a client's yelling or trying to hit, it's okay to remove yourself from that situation and say, do you know what? I think we both just need a break. We can talk again when you've calmed down. So setting those limits, those consequences, rather than being punitive. Recognizing that root cause of behavior. So why is our client acting out like they are? Is it that they didn't get enough sleep the night before? Maybe it is around the date that they experienced a traumatic event. So getting in there, understanding that root cause of behavior, and just knowing that the person's not just trying to be difficult for the sake of being difficult. Provide a safe space for the person to talk, give simple, realistic answers. And then probably anticipating those difficult times is going to be really important. So maybe the loss of a parent is very triggering for that individual. Knowing when that parent passed away, being able to anticipate that is going to be important. And then giving those warning for transitions. So 10 minutes until we're going to be doing this, or 5 minutes, and then we need to put the tablet away. Giving them a warning, giving them a heads up will hopefully make those transitions a little easier. And then of course, last but not least, is going to be a behavior program. So looking at possibly some type of therapy, social skills, all of those things would qualify. So let's move into compassion fatigue. So we just spent a lot of time talking about what does trauma look like for our clients. But when we are working with clients that have experienced trauma, that are going through a lot, sometimes we can also take on some of that emotional burden, which can result in compassion fatigue. It is going to be a syndrome that has stress-related symptoms characterized by emotional and physical exhaustion experienced by caregivers and other professionals in reaction to working with traumatized people over an extended period of time. I'm guessing many of you went into this field because you wanted to help people. You're empathetic. You enjoy helping people and making their life better. But the reality is us being empathetic individuals also puts us at a much higher risk from experiencing compassion fatigue. So who are some of the individuals that may experience compassion fatigue? Well, it'll be people who have not been direct victims of trauma, but have intense involvement with people who have been. So think about working at like an abused adult resource center, working with women that are coming out of abusive relationships. That individual themselves may have not experienced that trauma, but working with these women over time can increase that chance of that vicarious trauma and that compassion fatigue. What it can also do is reduce that ability to empathize or feel compassion for others. We kind of become numb to what other people are going through. Results in a decreased ability to cope with everyday environments. And then last but not least, vulnerability factors for compassion fatigue result from several different areas. So maybe not getting support at work, maybe engaging in mundane tasks, maybe feeling unfulfilled. Those are all things that can be vulnerability factors over time. So as I was talking about compassion fatigue, I'm guessing some of you said, wow, that sounds a lot like what we would call burnout. Compassion fatigue and burnout are two types of stresses. They bring about some of the same symptoms such as mental, physical, and emotional exhaustion. But when we're looking at signs of compassion fatigue, they're going to be headaches, sadness, grief. Maybe you're avoiding working with certain clients or people that have a certain type of disability or trauma. They may also experience nightmares, changes in belief systems. So compassion fatigue and vicarious trauma are two different things. So compassion fatigue, when we're talking about sadness, grief, nightmares, changes in belief systems, here we're looking at more of PTSD type symptoms, and that is one of the key marks of vicarious trauma. So people can have compassion fatigue without vicarious trauma, but oftentimes we are going to see vicarious trauma with somebody that also has compassion fatigue. Burnout is going to be a little different. This is going to be that cumulative process marked by emotional exhaustion and withdrawal, with increased workload, institutional stress that is not going to be trauma related. So compassion fatigue is related to trauma. Burnout is not going to have that trauma component to it. So who can experience compassion fatigue? Well, pretty much anybody can, especially those of us that are working in the helping professions. Doctors, nurses, counselors, social workers, case managers. That list is going to go on and on. People who provide care and assistance and support to others, they are more going to be at risk for this. Those qualities that make us really good at our job, our ability to relate to others, be empathetic, care about them, this is going to put us in that higher risk of experiencing vicarious trauma, compassion fatigue, those components. And this exposure could develop several symptoms that are associated with PTSD. So when we're looking at vicarious trauma, it is common to have many of the same symptoms that somebody who experiences PTSD would. So what are some of the causes? First of all, working with adults, especially with children who have experienced trauma or violence. When we're looking at the fact that about 64% of individuals have experienced one ACE, the chance we are working with individuals that have trauma is going to be very high. The lack of training in dealing with trauma issues. Do you always feel equipped to deal with what people are sharing with you? I remember being a first-year school counselor, having a student walking in and saying that they had suicidal ideation. I was way in over my head at that point in time. Although I had training, it was my first experience with this, and I just didn't feel super equipped to be managing that. Over time, I did different sessions, did further education, and I developed those skills. And I felt more equipped to deal with it when students came in and shared that with me. So getting more training in the area of trauma is going to be very important. A lot of us also have our own trauma, our own baggage, our things that we are dealing with. So having that past history of violence or trauma in our life can also impact that ability to work with clients. What does your self-care habits look like? Do you have self-care habits? And then, of course, that long period of intense work of working with individuals that experience trauma. So, is compassion fatigue a big deal? Absolutely. Because whether it is in our professional life or our home life, it is going to impact our life. So professionally, how is it going to impact us? Low motivation, task avoidance, poor work commitments. If you go in and see a counselor or a doctor and they're just going through the motions, can you sense that? Absolutely. Our clients, our students, the people we work with can sense when we are just going through the motions as well. So how does that impact our relationship with them? It's not going to help it, that's for sure. So making sure we're engaging with our clients, with the people we work with, is going to be important. Conflict between staff members, lack of job satisfaction, apathy, so that lack of interest that I just talked about. And then, of course, we can look at exhaustion, when you just feel like you don't want to get up, you're too tired to do things. And I do want to point out that when we talk about compassion fatigue, we are often talking about that flight, fight, or freeze response. We also know that procrastination can fall under that as well. Procrastination is actually a type of freeze and can be a trauma response as well. So if you work with an individual that's constantly procrastinating, putting things off, it might not be that they don't want to do it. It's just their way of managing their trauma symptoms or their trauma response that they have. So when should you ask for help? And here, when we're looking at compassion fatigue, we're really looking at more of those vicarious types of trauma. So that's secondary types of trauma. If you're experiencing difficulties separating work responsibilities from personal life, yeah, this might be a time to ask for help. Maybe talk to your supervisor, maybe talk to a coworker, ask them for some suggestions on how to separate the two. Have the idea and vision of the world in terms of victims or perpetrators. That is a very common PTSD type symptom that we can see, especially with vicarious trauma. And then last but not least is experiencing that chronic sadness and pain. But it's all not bad news. There are some things that we can do to help prevent or help if we are experiencing compassion fatigue or secondary type trauma. What are you doing for yourself and your own self-care? Self-care shouldn't be something that we reward ourselves with. It should be essential for us to be the best practitioners possible. I often find myself saying, well, I'm going to reward myself with self-care over this break. The reality is I should be doing something for self-care every day. Everybody should be doing something for self-care every day. So what are some of the things that we can do? Well, first of all, enjoy the little things in your environment. We cannot always change that working environment that we have. And we can't always change the tasks that we are responsible for. That being said, how can we make some of those tasks more enjoyable? For me, I would always, at the end of each semester, I would have to do credit evals, about 350 credit evals. So writing down the classes students took, how many credits they had, and the grade they received in it. It takes a very long time. It's very tedious and also very boring. So something I often did during that time is I would create a playlist of my favorite songs, and I'd listen to that music as I did that task. It made me happy. It brought me a little bit of joy while doing something that was rather mundane. Or how can you get some control in your work environment? For me as a school counselor, there were many times I didn't get a lunch, but some days I'm like, do you know what? I just need 15 minutes to myself. I need a 15-minute lunch break. I tell the secretary, nobody can interrupt me for 15 minutes. So if you get a break, if you get a lunch break, taking that dedicated time for yourself, whether it's just to go and sit by yourself, play on your phone, get a coffee, do that. It is important for your self-care. We can also look at that mind-body connection. And when we're talking about that mind-body connection, things such as muscle relaxation, mindfulness, feeding our spirit, those are all going to be a part of that. Feeling supported by your coworkers is also a huge part of that self-care practice. What can you do to connect with others in your environment that understand the work that you're doing? find that person for you. Find somebody that you feel that you can relate with and share stuff with. Another thing that I like to use that isn't necessarily on this list is a gratitude journal. So studies have shown if you keep a gratitude journal for 30 days, it literally rewires your brain. As human beings, our brains are trained to look for the negative things in our life. So it's very easy to look for things that went wrong that day. But when we start looking for positive things, our brain is going to rewire and look for the positive things in our life. So I would challenge you, if you felt down lately, for the next 30 days, write down 3 things each day that you are thankful for, or write down 3 things each day that went right for you. It could be as simple as, I'm thankful for having the 4th of July off. I am thankful that the ice cream I made for the picnic turned out. Very simple things, but when we start looking for those positives in our lives, it can make a huge shift in our brain. So how does this framework really fit into working with individuals that have disabilities? Well, first of all, this applies both to the people we work with, our clients, and then of course, it also applies to ourselves as well. It's not unheard of for people to go into the field of helping because they experience some type of trauma in their own life. So it gives people some self-control or a sense of control when they get to help others. So helping ourselves while helping others is going to be very important. And as we're looking at over time, everybody is going to develop their own survival and defense mechanisms. Those that have experienced trauma are probably going to have more survival and defense mechanisms. Have you ever had a bad day at work and when you got home, you were short with your spouse, you were short with your kids, maybe you were a little crabbier than usual? Well, this is actually an example of a defense mechanism that we call displacement. So instead of maybe getting mad at our boss, getting mad at our coworker, getting frustrated with our client, we hold that all in, we take it home, and then we take it out on the people that we love and that are closest to us. Our clients are going to have a variety of their own defense mechanisms. Understanding what they are and how they come out is going to be important. Like I said, I like to believe most people are not difficult just to be difficult. There is probably some underlying reason that they are engaging in that type of behavior. And the behavior we're seeing is a type of defense mechanism or survival mechanism that they've had to develop over time. So now we're moving into what does trauma-informed care look like? Really, there's going to be 4 key elements. So realizing the impact that trauma has, that's what we're doing right now. What are the symptoms of trauma? How can we help our clients? What does it look like when we're experiencing that secondary trauma, and how can we help ourselves? Recognizing the signs and symptoms, responding to our clients that have trauma by integrating knowledge about trauma into policies, procedures, and practices. And then last but not least is going to be resisting that urge, or not necessarily that urge, most of the time it's unintentional, but resist re-traumatization. What we mean by that is avoiding or creating an environment that inadvertently reminds patients of their traumatic experiences and causes them to experience emotional and biological stress. I've worked with young ladies before that I had a student come into my office and she's like, I just need to take a minute. And I'm like, okay, I tried not to push. Sometimes you push, sometimes you don't. And she ended up opening, I said, what's going on? And she shared that somebody that walked past her in the hall wore the same cologne as somebody that sexually abused her. So being aware of maybe smells, pictures, noises that may be triggering to your client, often it can be those sensory type things that can create that re-traumatization for that individual. Like I said, most of the time it's inadvertent. People don't mean to, but just being aware and cognizant that that can occur. And then we have kind of our roadmap of what trauma-informed care looks like. We don't have a lot of time to go over this, but first of all is going to be that recognition and awareness. So kind of what we're doing today, talking about what is trauma, what is that going to look like? Then we move into that trauma sensitive stage. So training all of our staff in terms of what is trauma, how are we going to respond to it? and also making sure that we have agency readiness and supervisor buy-in. Has anybody tried to engage in an initiative without administrative support? Maybe. Did it go very well? Yeah, probably not. So having that administrative buy-in, having the support you need, the resources you need to engage in this is going to be important. Process and infrastructure. Phase 3 is going to be trauma and responsiveness. Probably prioritizing what is the first thing we want to do in terms of informed care is going to be important. When we talk about this, most people are going to pick a low-lying fruit. So they're going to pick something that is going to be the easiest to change, or that's going to have the biggest impact for our participants, our clients, and then also our staff. And this isn't an ending process. Once we get to that trauma-informed stage, we need to implement and monitor what is going on. We need to see, as our process is working, are people staying up to date on their training? Do we need to change something? And then looking at our practices on a regular basis. So evaluating on a regular basis to make sure it works is important. And this does not happen overnight. This process is going to take time, dedication, and then it's going to be an ongoing process. So if today you're like, we are going to become a trauma-informed care practice, that's great. You can start doing little things tomorrow, but it is going to take a little bit of time for everybody to jump on board and to be a fully trauma-informed care provider. And then trauma-informed care should shift the conversation away from what is wrong with you to what happened to you to elicit this response. Thank you. I'll hand it back over for the case study.
Oh, it looks like we have a question.
Okay. In the chat.
I believe somebody had raised their hand, but they might have done that on accident. But if you do have a question, feel free to unmute if you'd like to. In the chat, we're seeing people commenting throughout your presentation. You know, it's really important to use some of these strategies like having a routine and setting limits to minimize compassion fatigue, and also creating gratitude journals. I've never done a gratitude journal, and I think it's probably time to actually start one, honestly. I recently came across a study that had talked about like the people that said that they experienced the most joy in life, like actively practice gratitude, which I thought was really interesting. Not just saying like, oh, I'm just grateful for, you know, like it's a beautiful day. I'm grateful that my cat is sitting on my lap. It's like actively seeking that out. And I just think that that's really wonderful.
And it's a great practice to do as a family. To be perfectly honest with you, my oldest can be a little negative at times, so can my husband. So sometimes at dinner, we're like, okay, for the next 30 days, we're all sharing things that we're grateful for. That went well for us today. So it's a really good thing not to just do for yourself, but also do as a family activity as well.
Yeah, absolutely. I always have to try to shift my kids because they always focus on the negative too. So then it's like, oh, well, what's something really great that happened to you today? And why was that your favorite part? So
Yeah.
that's a daily redirection for us.
Yes.
And yes, it is much easier to complain. I agree, Karen.
Yeah, it is.
So I'm noticing this quote. Are you familiar with Dr. Perry's work?
Yes, I am.
Okay, I see a hand is back up. Do you want to ask a question? Carla, I see your hand is up.
You're on mute, Carla.
We'll give you, oh, there you go.
Okay, no, I accidentally did it, but I haven't been able to, I can't type anything in the chat. I don't know why. I used to be able to, but this one I can't do. So,
Oh, no worries.
Okay.
Thank you.
Yep.
Yeah, I was just mentioning, Dr. Bruce Perry wrote a really great book called What Happened to You. I highly recommend reading it. It was kind of a game changer for me, and just having a better understanding of what happens when you are actually in that trauma response. I don't know if you're familiar with his brain pyramid that he showed. I loved that image.
Yeah, we did a lot of Bruce Perry work at Bismarck High. So we really like him. And I think that's really where Bismarck Public Schools has taken their trauma-informed practices from, is a lot of his work.
Yeah, because he's from Bismarck.
Yeah.
Yeah, that's really great.
So, yeah, great test.
Yeah, so yeah, we'll include that in the additional resources, which we still need to send out last week's additional resources. So if you haven't already checked it out, it's a wonderful, wonderful book. So yeah, we'll go ahead and we'll pass it over to Kyle Erickson. He's going to be our case presenter today, and he's going to share his experience with lived experience and overcoming trauma. So please welcome Kyle.
Yeah, thanks, Krista. So a couple of things that you need to know about me before I kind of dive into this this story and kind of my experiences. So I've been on antidepressants since 2015. So okay, keep that just in your back pocket. And also since August of 2020, I started performing as a stand-up comedian, just as kind of a side hustle. Okay, that's another thing. So around spring of 2021, my life was in a place where I felt, confident in my life, that my life was, going in a direction I wanted to go in. So I just stopped taking my antidepressants, which if you're a professional in the field, that's a big no-no. So while I was, I didn't even like wean myself up. I just stopped cold turkey. Around the same time, I made the decision to move from mine in North Dakota to Minneapolis so I could pursue my stand-up comedy not full-time but more aggressively than I was able to do here in Minot. So the problem with that was I wasn't working at the time, and I'm a wheelchair user, so for me to move, it's kind of an undertaking because I need to find accessible house and then all all that. And I found one. I even found a job that I was gonna work for the USDA. Problem was between the stress of me trying to figure out how this move was gonna work and my me just going cold turkey for my antidepressants. I was such in a place that it was traumatic for me because I was just, I didn't have anything in my cup so I could keep on. And something that I didn't realize started happening was my cognitive function started taking a hit. My decision making skills really took a dive. So while I was trying to, find a place to live and, make all these preparations to move, I just couldn't, function. That, and I lost a lot of weight. Within 3 months, I went from 218, healthy dad bod, to 175. And the problem with this was a lot of people were complimenting me on how good I looked. And so that caused a lot more stress because it gave me a little bit of body dysmorphia. And to this day, I don't think I look good unless I'm a bit chubby. And what happened was, since I wasn't taking care of like my mental health, I had a mental breakdown in Minneapolis after I moved, and I ended up having to move back to Minot, kind of with my tail between my legs, so to speak. And so basically, I don't know if that move would have went well if I would have, stayed on top of my mental health or stayed on top of my antidepressants. But I know that I would have had like a deeper cup to like handle everything. And so I ended up back in North Dakota, and I ended up being hospitalized for it. And the problem that I was having was a lot of the professionals didn't realize that I had recently gone through something. So they thought that this was just, oh, they put me on all these like antipsychotics and stuff. So I went from being non-medicated to being over-medicated within a couple of months. And that made things worse because then I started, I was getting brain fog and all sorts of things. And it took a while to get a handle on everything. Honestly, the thing that kind of started turning things around for me was this job. I kind of found a new purpose in life. And what I noticed with trauma, sometimes the fastest way to get over trauma is to kind of redirect yourself. Find a new goal, okay, this is what I have to do this is my purpose in life. And so yeah, and 2 years from what happened, I can look back and I love the fact that I can use what I went through to kind of help people, like, so they don't have to go through the same thing. But yeah, I guess the main takeaways are stay on prescribed medication and just, self-care, make sure that you're doing what you need to do to keep your health full so that when important life events do come around, you have the emotional stamina to kind of deal with those. So yeah, it's a short case study today. I just want to let you a little bit about my experiences. Thanks for the time, guys.
Thank you so much, Kyle. I mean, there's so much stigma around mental health and sharing your story. So sharing your story is so impactful.
Well, absolutely, because I was the biggest uh I never talked about my mental health now, and I brag about, when I have a really good therapy session, I brag about it, and I don't know, which is just wild to me, because 3-4 years ago, that wouldn't have been me in any way.
Yeah, and it's so funny because I met you on the tail end of everything where you
Yeah,
seemed like you were pretty open about that. You've always been very like, oh yeah, I saw my therapist today. And so I was like, gosh, that's so cool. But it's just great to hear that your experience with moving back and finding a job and finding that purpose is really what kind of made you comfortable. So I mean, it kind of goes back to that whole community and connection piece that we've been pushing throughout this series of how important it is to just have that social support where you can feel comfortable coming forward with all that. We're seeing a lot of thank yous in the chat. Do we have any questions for Kyle or Kayla? Yes. Thanks for normalizing taking meds and attending therapy. Absolutely. I've made that mistake before too of like, oh, I'm doing great. I'm just going to quit the antidepressant.
oh no, I was reading this study, unfortunately I read it after the fact, but like how the chemicals that antidepressants help with, just by taking them cold turkey, you would draw your levels drop down below, like, past, even if you've never taken antidepressants, because your brain becomes reliant on it.
Yeah, some absolutely terrible things could happen if you were to just quit it cold turkey. So talk to your doctor before making any big decisions. Another good takeaway.
Exactly.
Well, I am not seeing any additional questions in the chat. So thank you so much for all the wonderful presenters, Kyle, just by being the case presenters on it with our evaluation. So please take a moment to fill out our evaluation. It's there in the chat. And we hope that we see you next week. We're going to be talking about the 8 dimensions of wellness, and our case presenter is actually going to be Amy Silverwood from the First District Health Unit, and she's going to talk about Credible Mind and this free resource that's available for everyone. So thank you again, everyone, so much.